A 34-year-old female presents to the ED with increasing low abdominal pain. She was seen by a colleague a week ago and diagnosed with an early ectopic pregnancy in her left fallopian tube. Her OB was consulted at that time and the patient was started on methotrexate therapy. What is the most likely cause of her abdominal pain? A. Treatment failure and increasing size of the ectopic pregnancy. B. Tubal rupture. C. Appendicitis. D. Separation pain from methotrexate use. E. Pelvic inflammatory disease, PID. Answer D. A large percentage of women, estimated to be from 30% to 60%, experience abdominal pain approximately 1 week after starting methotrexate for ectopic pregnancy. This is known as separation pain, as it is thought to result from tubal distension as a result of tubal abortion or hematoma formation. However, all women with a history of methotrexate treatment for ectopic pregnancy who present with abdominal pain merit further investigation by ultrasonography to explore the possibility of tubal rupture. Interestingly, the size of the ectopic mass may actually increase before involution, but this finding has not been shown to be associated with treatment failure. However, if patients have an increase in the amount of pelvic free fluid or a decrease in their hemoglobin, a presumptive diagnosis of tubal rupture should be made, and an OB should be urgently consulted. Although it is a risk factor for ectopic pregnancy, active PID at the same time as pregnancy, ectopic or intrauterine, is extremely rare. A 28-year-old female presents with fever and painful oral lesions for 2 days, as shown in figure. Which of the following is the most likely cause? A. HSV-1b, HSV-2c, Epstein-Barr virus D, Coxsackie virus E. Group A. Streptococcus. Answer D. The patient has vesicular lesions on the soft palate consistent with herpangina, caused by Coxsackie virus. In children, this often presents as hand-foot-mouth disease. Management is supportive, with special emphasis on pain control, as lesions are extremely painful and can limit oral intake. HSV-1 can cause herpetic gingivostomatitis, which causes lesions on the hard palate and gums and can be treated with valacyclovir. HSV-2 usually causes genital herpes rather than oral lesions. Epstein-Barr virus causes infectious mononucleosis, resulting in pharyngitis, usually without discrete lesions. Group A Streptococcus causes strep throat, a pharyngitis with exudate on the tonsils but without discrete oral ulcers. Which of the following is the optimal vascular access for adult trauma patients? A. Single 14G peripheral IVB. Double 16G peripheral IVs. C. Double 18G peripheral IVs D. Single triple lumen catheter. E. Intraosseous catheter. Answer B. Trauma patients require rapid access with large-bore peripheral IVs to optimize fluid administration. 214G or 16G IVs are ideal. Rate of fluid flow is inversely proportional to the length of the vessel and directly proportional to the radius of the vessel to the fourth power. Therefore, short, wide-bore catheters are preferred over long, narrow-bore catheters. A single IV is not adequate, given the risk of expulsion from patient movement during trauma resuscitation. Triple lumen catheters, though generally large-bore lines, are limited in their fluid passage rates by their length, which can be up to 10 times that of a peripheral line. Cordis catheters are shorter than triple lumens and they are large-bore, 8.5 French. Thus, they can achieve significant infusion rates with a pressure bag or pump and are often included in trauma resuscitations when massive transfusion or fluids are needed. Intraosseous catheters provide ready vascular access in pediatric patients but are not preferred in the adult trauma patient due to limited flow rates, difficulty of placement, and potential complications.